what I'm going to do is go through a little bit about chronic lymphocytic leukemia, explain a little bit about the disease itself, explain how we might look at particular patients and see, if we can anticipate how their disease will behave. And then also I'll talk a little bit about the treatments that we currently give, why we give them, and then I'll also go on and talk about some of the newer treatments and how things are changing in CLL. And then you can add questions in as you go along, as Ali mentioned, by typing in, and also you can ask me some questions at the end, hopefully. So CLL, so it's a very common type of adult leukemia, and mainly because people who have the disease often survive for very long periods of time. So it's not necessarily the fact that it occurs more commonly, but it's the fact that people who have the disease, have it for long periods of time. So there's a lot of people out there in the community with CLL. Often the diagnosis is made by an abnormal blood test, which may well be picked up totally by coincidence. People will have a routine blood count through the GP, or related to some surgical procedure, or coming to hospital for some other reason. So we will see an abnormal blood count, and I think I've got some film to show you in a while, and we will see the abnormal cells, and what we will do a test called flow cytometry, and that's what this complicated thing here is all about. So the abnormal cells express proteins on the surface of the cells, and those proteins all have these names. They're on CD and a number. CD just means cluster of differentiation, but so they're all a variety of proteins, and these kind of proteins on the surface are very typical of CLL, and in particular, CD19, 20, 23 can occur on normal B lymphocytes, but the CD5 is usually only present on T cells, so that the combination of these T cell markers and the B cell markers all on the same cell is is characteristic of CLL. And I might mention a little bit more about that as well. So the median age for patients is 72 there, so a lot of patients do present in the later years of life, but a small percentage, less than 10% there, that will present around about my age, around 50 or so. It is more common in men than women. Exactly why it happens, we honestly don't know the answer to that. There may well be some degree of environmental or occupational exposure, and certainly chemicals like Agent Orange, which is a pesticide used in the Vietnam War, there does seem to be an increased incidence of some kinds of malignancy, including CLL. So the American government actually does recognize it as a disease that may be related to the service within the army, and patients therefore can get pensions on the basis of that. Very occasionally there are patients who do seem to have a genetic predisposition, but by far the majority of people there's no obvious family history of leukemia in other family members, and even if you do have the predisposition, you're not necessarily guaranteed to develop the disease. So majority of patients, it's not a disease that's typically inherited. It will usually just occur sporadically with no other family members affected. So one of the early attempts to try and stage how this disease behaved was really by Rai, and you can see at the bottom right there, a lot of this data was from a long time ago now, so 35, 40 years ago. And Rai is still alive, and he works in New York, and his initial staging was based on clinical findings. So if you look over on the left column up here, and you'll see the findings that he looked at, which were things that the doctor could see when they were face to face with the patient in the clinic. So you might see a lymphocytosis, or high lymphocyte count, the presence of swollen lymph nodes. So when the doctor examines you, he'll palpate the neck and under the arms and the stomach and the groin, trying to feel for these lymph nodes. And then patients may also have a swollen liver or a swollen spleen, which is the organomegaly. And then potentially on the blood counts, it would have anemia and possibly a low platelet count, this thrombocytopenia. So what Rai did was to add all of these things together, and he could stage people on the presence of these abnormalities. So if you just had an elevated white count but no other abnormalities, you would be Rai stage 0. Whereas if you had lymph nodes plus the high white count, stage 1, and so forth, and then eventually the latest stage of the disease, stage 4, would be if you had a high white count, lymph nodes, palpable liver and spleen, and then anemia and thrombocytopenia, and that would put you into stage 4. And the benefit of this really was that it gave an idea really of what the expected survival was for these patients. So you can see over in this right column here where it's got median survival. So that's the average survival for patients within this group. So patients with just an elevated white count without other abnormalities, could be expected to live for, on average, 12.5 years. Some of them would live longer than that. Similarly, if you went all the way down to the most advanced stages of the disease, so stages 3 and 4, they would have survivals or average survivals of only a couple of years. So being able to predict what stage of the disease the patients had was useful from the point of view of the doctor, from how you might manage them, and also from the patient as to how likely the disease was to progress and what your likely survival would be. Binet is a French classification, as you can see, a little bit later than the Rai classification. This is mainly used in Europe, so Binet's French, and we tend not to use any of these classifications much these days, but they're still widely discussed. We would use Rai mainly in Australia and the US and the UK, whereas Binet more in continental Europe. And again, similar kinds of things in the presence of the number of lymph nodes that you have involved, the presence of anemia, presence of thrombocytopenia. Again, so all of these things just help to predict, how severe the disease is and what your likely survival is from the disease. But really, it's relatively crude, and there are probably better ways to actually, look at how we can predict how people's disease will progress. So one of the ways, again, he's been around for a long time, and this was described in '86 there, so 30 years ago. And what this is looking at is the time for the lymphocyte count to actually double. So when you go along to clinic and you see the haematologist, they will tell you that your white count is 14 and your lymphocyte count is 10. And then next time you go, your lymphocyte count may have gone from 10 to 15 or 10 to 20 or 10 to 30. And that's really what this doubling time is looking at. So it's looking to see if your lymphocyte count goes from 10 to 20, how long does it take for that to happen? And then the next time you go, it will be double 20 to 40 and then 40 to 80. So if your lymphocyte count is doubling within less than 12 months, then generally you tend to have a worse survival. So this curve, that's what these two curves here show. So this axis on the y-axis here, that vertical line. So up at the top, that's 100% survival, and then down here is 30, 20, 10% survival. So you can see by about 7 years there, 80 months, you've got about 20 to 30% survival. And if your doubling time is less than a year, compared to a 90% plus survival if your doubling time is over a year. So if your white count stays stable over long periods of time, then that's a good sign. If your lymphocyte count is increasing in short periods of time, less than 12 months, then that's not as good a sign. So that's actually very easy to measure and quite a valuable piece of information there. You don't need any sophisticated laboratory testing whatsoever for that. We do have more sophisticated testing, so these are some of the other things that we look at. And beta-2 microglobulin is one of the measurements we can measure. Beta-2M is a protein that's present on a variety of lymphocytes, but it reflects the amount of leukemia that people have. And it's also a good prognostic indicator in another disease called myeloma, which is a similar disease to CLL. And what you're looking at here is the level of the beta-2M. And so, sorry, some of these slides are a little bit confusing. So this is a low level, less than 2.1, and that's the blue line. And then you've got a high level, which is this pink line here. And again, the quicker the line goes down, the worse survival it is. So what you want is for this line to go right the way across here, which means that everybody's alive 18 months later. But as you can see, if your beta-2M level is high, the likelihood of disease progression is much greater than if your beta-2M level is lower, and that's this pale line here. And again, you've got a couple of groups in the middle, depending on what measurement of the beta-2M you have. So again, it can be a useful feature. So if it's measured at the point here, you can actually, again, predict how people's disease is likely to progress. We do a lot of genetic testing now, so most people will have some form of of chromosome testing when they're diagnosed with the CLL. CLL is quite difficult to do genetic testing in because the cells don't divide very well. So we tend to do a technique that's called FISH, and I'll show you some pictures of that shortly. So that's what's called fluorescent in situ hybridization, and we have a fluorescent probe, and we can look for particular chromosome abnormalities. As I mentioned, normally the cells don't divide very well, so trying to do standard chromosome testing is often very difficult in CLL. Now, people can have no chromosome abnormality, or they can have a variety of other chromosome abnormalities, and these are the most common ones. So again, you may be familiar if you have a particular abnormality yourself. So probably the most common one here is abnormalities involving chromosome 13. The Q means long arm, and the 1-4 is the position on that long arm, whether it's near the top or whether it's near the bottom. So that's a particular genetic abnormality which occurs in CLL, and you can see up to 2/3 of people will have that abnormality. And in this situation, 13 is lucky rather than unlucky, because people who have this abnormality tend to have good survivals, as you can see here, 300 months, maybe up to 10 years on average survival with this abnormality. Other abnormalities are perhaps a little bit less common, so maybe up to 1/3 of patients with this. It means trisomy 21, so trisomy 12, 3 copies of chromosome 12 rather than 2 copies, which is normal. And that additional copy, again, is associated with CLL. And again, they tend to have a little bit more aggressive disease than the 13q abnormalities, but not too bad. Deletion 11q abnormalities, a little bit worse than the 12, but really the worst of the bunch, although fortunately it's relatively uncommon, are these mutations in chromosome 17. And P53 is the gene that's involved with that, which is a tumor suppressor gene. So normally we all have 2 copies of P53, and if that gene is active, it stops you getting leukemia, or stops you getting a variety of cancers, in fact. And if you get loss of that gene, then it makes you more susceptible to cancer. Sometimes people will get loss of 1 gene, and sometimes people will get loss of 2 genes. So the presence of abnormalities in that gene area is associated with more aggressive leukemia in this situation. And you can see that the survival in people with this genetic abnormality on average is 3 to 4 years, so much different than this one where you've got survival of 10 years or more. So genetic analysis is very important, and it's I'd say performed routinely now in the majority of patients with CLL. So this is what the pictures look like in FISH, and I thought I'd just show you so you get a bit of an idea of what we're looking at. So if you look over at the cell on the left here, and you should be able to see the pointer, this is a normal cell, and you can see 2 R2G, so 2 sort of red signals, slightly pinky reddy colour, and then you can see these two green signals. So that's normal. So what you've got is a red marker on chromosome 17, so that's telling you you've got 2 copies of 17, and you've got 2 copies of 11, and that's normal. On this cell here, you've got 2 green copies, but you've actually only got 1 red copy, so 1 red chromosome. So basically, one of your 17 chromosomes is missing. So you've got a deletion of that particular gene. So this is the P53, which I mentioned tends to have a worse prognosis than average. This one over here actually has 2 copies of the P53, the 17P, but there's only 1 green signal, which tells you that you've got a deletion of this part of chromosome 11. Okay, so we can look under a microscope, and we can look for these abnormalities, and generally we would look at about 200 cells, and we'd be able to tell, up to, with the sensitivity, about 1%. So if you've got even 1% of cells with CLL, we should be able to find an abnormality there. So this is something that we commonly use to try and help us predict how people will do with the disease. And then just to show you that graphically, so again, these are the different, each line is associated with a different chromosome abnormality. So the 13, which as I said is lucky, actually does better. So you've got 100% survival at 0 months, but then if you go out to 2 years, 4 years, 6 years, 8 years, then you'll see that unfortunately people with the leukemia will die. I mean, people in the 70s obviously may die of other issues as well. But people with the chromosome 13 tend to have a much better survival than people with the 17p deletions, which, the line drops off very rapidly. So only a half of those will be alive at about 2 years there. Whereas for this, the yellow line, the chromosome 13, half of them are still going to be alive at, 10 to 12 years, from diagnosis. So as you can see, chromosomes, very important there in predicting survival. Sorry, I'll just cancel on my phone. I should have turned that off. Okay, apologies for that. So how else can we do it? So cytogenetic analysis is very important. But one of the other things is to look for other laboratory tests. A lot of these next 3 slides are really research-based things and often not routinely available in a lot of hospitals. We can look at whether the gene mutations. This is a variable heavy chain. So it's a part of a protein of immunoglobulins or antibodies, which we all have. And generally, the gene will be mutated in normal lymphocytes, normal B cells. But if it's unmutated, that suggests a more malignant phenotype, really. And really, just to show you here, if you've got cells here that are mutated, again, the curve's a little bit flatter, so they have a better prognosis than if it's mutated. Sorry, if it's unmutated, and it goes down like this. So again, looking at these gene mutations can be helpful, but as I mentioned, probably most of you won't get that tested, really. Again, this just adds on the P53, and even allowing for these other factors, the P53 is still by far the most important prognostic factor there. CD38 is another protein that's present on lymphocytes. And again, we can do that in our routine flow cytometry panel. The presence of larger amounts of CD38 is associated with a more aggressive leukemia as well, and the presence of small amounts of CD38, again, with a more benign leukemia. So that can be helpful, and a lot of laboratories actually will measure that now. But again, often people will have multiple factors, and it's a question of some will be beneficial, some will be detrimental, and it's a question of what the overall balance of that is. ZAP70, if you go on websites or read blogs or whatever, you'll almost certainly see this thing called ZAP70. This is a zeta-associated protein, and again, in some of the publications, it looks to be a very useful test. So patients who are ZAP70 negative or less than 20% positive cells, again, have a very good prognosis, very good survival, whereas patients with lots of these cells tend to not do quite as well. Now, the test is technically very difficult to do, and again, we do it on a little bit of a research basis, but it's often not a routine test, and again, a lot of the private labs won't necessarily do this test, but it's something you may see about, and it's something that does have some prognostic significance. CD23 is one of those proteins on the cell surface of CLL mentioned earlier. Some of that protein breaks off and floats around free in the plasma, in the bloodstream, and so this is soluble CD23, so it's little bits of protein that are broken off and are free in the plasma, and again, you can measure that, and really it just reflects the more cells you've got, the more of this soluble protein is present. So high levels, which is the green line, again, tend to be associated with a slightly worse disease. So really, all it's doing is mirroring the amount of disease that's present. Again, not something that's routinely used. Okay, so the first part there really was to look at, what tests can we do and how can we give you an idea and give ourselves an idea of how the leukemia is likely to progress over the next few years. Because the first time we see you, we can't predict the future. We have to try and work it out from a variety of tests there and get a bit of an idea of will the disease stay stable for a long time, or is it likely to progress rapidly, and do we need to do something about it earlier rather than later? Now, one of the things people often ask is, if you know that I've got leukemia, why don't you want to treat it now? Why you do nothing? Why do you just wait and see? So that really comes from fairly good data, old data from studies using a drug called chlorambucil, and more recently from this CLL7 study. And that data really showed that it didn't seem to make any difference when you started the treatment. It doesn't actually improve overall survival. So patients don't live longer if you treat them right at the beginning. rather than if you wait till they get symptoms, which may be 5 or 10 years down the line, the survival will be just as good. And in fact, this CLL7 is a recent study looking at a combination of chemotherapy, which I'll talk more about, called FCR, versus initial observation. So what happened here is some patients were treated at diagnosis with FCR, other patients were just monitored, just watched, and then when they progressed, then they were given FCR. And that study clearly showed that there was no difference. So there's no benefit to treating people early. You give them side effects with the chemotherapy, which you don't necessarily need to have for an extra few years potentially. So why would we decide to treat you? And that's often the question. You go and see the doctor and he keeps checking the blood count and examines you, but why would you start treating somebody? When are you likely to benefit from it? So these are generally the most common reasons. So this is the International Workshop in Chronic Lymphocytic Leukemia from 2008, and these are the recommendations as to when you should consider treatment in patients. So in people who've got enlarging lymph nodes, so where the lymph nodes in the neck or under the arms or in the groin are enlarging, and when the patients are getting symptoms from them, so if the ones under their arms are very uncomfortable or the ones in the groin are uncomfortable, and certainly once you're getting glands of 10 centimeters, which is the size of I guess of a tennis ball, something like that, fairly decent size. Similarly, the presence of an enlarging spleen, which will occur on the left side of your abdomen, up at the top there, just under the ribs, that can cause pain and discomfort and a feeling of fullness of the stomach all the time. People get low blood counts because once the leukemia starts to take over the marrow, the normal cells are diminished, so people become anemic. They get low platelet count. So again, once that starts to happen and the normal marrow is suffering as a consequence of leukemia, that's an indication to treat. And then often a common one is when people just feel ill. Sometimes in the early stages of CLL, you don't even know you've got it. It's an incidental blood count and people feel fine. But once you start to feel sick, then you need to think about doing something. And occasionally some of you may have had problems with either an immune thrombocytopenia, what's called ITP, or an autoimmune hemolytic anemia. So sometimes the leukemia can produce antibodies that can destroy your own red cells or platelets, and that can be a problem. So we would treat on the basis of that. So generally we don't need to treat people on the basis of a lymphocyte count. A normal lymphocyte count would go up to about 10 at the most. So here you're looking at 300 is 30 times normal range, but you can allow patients' counts to go into into the hundreds without necessarily treating them, provided you've not got any of these problems. And the doubling time in itself is not an indication for treatment, but would probably make you anticipate that look, the way things are going, we're probably going to have to treat you in 6 months or a year, because by then the counts are going to be picking up quickly. So we will look at a variety of these clinical parameters and to decide when you're likely to benefit best from treatment. So the big problem with the treatment is really what you're looking at is the efficacy, how well the treatment works, versus how sick the treatment makes you, the toxicity of it. And unfortunately, the two things are often, they go hand in hand. You can't really separate them. So if you look down at the bottom here, you can look at drugs like chlorambucil, which you may all have heard of, just a simple tablet. You've got rituximab, which is an antibody therapy, and they're well tolerated. So the toxicity is quite low, which is this sort of triangle here. But at the same time, the efficacy is not that great either. On their own, they're not particularly strong treatments. Whereas if you go to the other extreme, you've got your FCR, fludarabine, cyclophosphamide, rituximab. The R is the same as this rituximab here. And you can see that's much better treatment, but at the same time, the toxicities are much greater. So grade 3, grade 4, and that's greater than grade 3, grade 4, grade 3 plus toxicity. So those are severe side effects. And the more treatment you give, 3/4 of patients here will be getting severe side effects related to the chemotherapy. So you have to bear in mind, how good the treatment will be, but also how much damage the treatment will cause as well. So on the basis of that, what we try and do is think, well, what treatment should we give, and is the patient likely to tolerate it? So there's two ways you can look at that. You can either look at the patient themselves and say, look, how old is the patient, or better, because these, ages, people of the same age can be physically very different. So we often look at the functional status, how fit people are, basically. So, obviously the older you get, you tend to get a little bit unfitter, but we see very fit 70-year-olds, even 80-year-olds, and we've got an 84-year-old lady having chemotherapy at the moment who's remarkably fit. But at the same time, you see 50-year-olds who've got lots of other problems. So you can look at the age of the patient, although age on its own isn't a great indicator, and that's often what they do in the US. Otherwise, you can look at things, what this is called a SIR score, which is a comorbidity index. So it's a score. You go through a questionnaire, and it will ask about heart disease and kidney disease and lung disease, and then you get so many points for each of those abnormalities. Then on the basis of that, you can pick a score as to how what other illnesses, what other comorbidities patients have, and that may suggest that you should go for a milder form of treatment if they've got a high SIR score, compared to a more aggressive form of treatment if they've got a low SIR score and therefore are physically very fit. One of the things that's very important is renal function, which is this creatinine clearance. And renal function is particularly important because fludarabine, that one of the main drugs in CLL, is excreted in the kidney, and if you don't have good kidneys, you can't have that drug. So you can look at the age, and you can look at how fit people are, or otherwise you can, or probably in combination, you can also look at the genetic features. Now, I mentioned that to you earlier. So this, the P53 mutation there, those patients tend to do, significantly worse than some of the other subgroups. So those patients, you would definitely want to try and treat with more aggressive treatment if you can, and try and control the disease. And similarly, patients who've got good markers, favorable markers, like the chromosome 13 abnormalities, you would decide, well, look, they're probably going to do pretty well. I won't treat them yet. So we look at a few things, and we try and decide, to the benefit of the patient, what treatment we should give them, and try and get a good response, but with minimal side effects. So this is the combination, really, FCR, which is the gold standard, and I won't go into this in great detail, but it's a German study, a CLL8 study, and you can see large numbers of patients, 800 patients with untreated CLL, and you can see here the SIR score. So these are patients who are physically well, with a low SIR score, less than 6 there, and a good kidney function. So you've got your fludarabine, cyclophosphamide, rituximab, and this was the first study that added in monoclonal antibodies. So these first two drugs are chemotherapy. The rituximab is an antibody against the leukemia, and so half of the patients got the antibody plus chemo, the other half got chemo, no antibody. And really this was the first study to show that the combination of chemo, which the chemo plus antibody, FCR, versus chemo alone, was better. And adding in the antibody improved, this is overall response rates, complete remission rates, and also improved progression-free survival. So that's the time from when you have your treatment, the disease disappears, until the time the disease starts to come back again. So if you had the antibody plus chemo, it would be taking 52 months before it came back on average, whereas if you just had the chemo without the antibody, it would be taking 33 months. So, you're looking at a difference of almost 2 years there between the time coming back. And again, a little bit of an advantage in overall survival, but if it does come back, obviously some of these people would have further treatment, which is why the overall survival is not necessarily dramatically affected, whereas progression-free is. MRD is minimal residual disease, so if at the end of your treatment there's no detectable disease, then that's a very good sign, and it means it's going to take a lot longer for the disease to come back. So in MRD, there are more sophisticated tests that we can do. Again, a lot of it is research-based at the moment, but being able to show that the disease has disappeared by flow cytometry, disappeared in the bone marrow on the bone marrow examination, and maybe disappeared on fish, is a good sign, and means that you're going to have a longer response. Unfortunately, even though FCR is a very good therapy and really the gold standard, the best therapy at the moment, anywhere in the world, wherever you go, it still doesn't work particularly well for this P53 abnormality. So that group, it does badly, and even with the best treatment we have, it really doesn't respond as well as we might hope. So we need to look at this group for newer treatments, something that's a little bit better. Okay. So because fludarabine is quite toxic, and because we can't give it to people who've got renal impairment, then people have looked at using other alternatives. So this is a drug that some of you may have heard of, a drug called bendamustine. Unfortunately, at the moment, it's still not available in Australia, but hopefully in the next year or two it will be. There are clinical trials where it is being used, but bendamustine, it looks to be, if you compare it to fludarabine here, the response rates, if you look at overall response rates, nearly everybody is getting some kind of response. And overall, they're pretty similar. So this is CR is a complete response, CRI is complete response, incomplete, don't worry about that, but and a PR is a partial response. So you can see that generally the fludarabine is slightly better, but really, the BR is pretty good, and the side effects are significantly less with it, which is the big advantage. So it's a good alternative if your doctor feels that perhaps the fludarabine is going to be a little bit too much for you. So these are the suggestions, again, that perhaps how we would look at people who, and as I say, the average age at presentation is 72. So, but we regularly have people in late 70s, 80s with the disease. So, in patients who are perhaps at the older 70s, 80s, where we don't think they'll cope with fludarabine, the other options are perhaps to look at bendamustine, which at the moment isn't freely available in Australia. The other alternative is using chlorambucil, and chlorambucil is a tablet therapy that's been around for probably 50 years, been around for a long time. And also often used in combination with rituximab, which is a monoclonal antibody that's given by drip. So the chlorambucil is given by tablet, and there's a variety of combinations. It can be given, this one's 7 days per week each month for 6 to 12 months of treatment, but sometimes it's given continuously daily, sometimes it's given every fortnight. It probably doesn't matter how it's given. There's a variety of regimens. Antibodies. So rituximab is a half human, half mouse antibody that's aimed at CD20, which is a protein on the leukemia cells, and it's certainly effective treatment. It's used in a variety of non-Hodgkin's lymphomas as well as CLL. And rituximab is made by one of the drug companies, Roche, and in fact it's been around for probably 10 years now, and it's about to come off patent fairly soon. And because of that, anybody will be able to make the drug at a markedly reduced price. So the company are looking for a newer version which will be patentable and will means that nobody else can make it. But also that to be fair to them, I guess they're looking at making a more potent drug as well. So this Obinutuzumab is a new drug, and in fact it's just been listed on the Australian market as well. So this is the antibody, and I won't go into any detail, but it's called GA101, and we've had clinical trials on it at the PA, and I'm sure several of the hospitals in Brisbane have as well. So you don't need to really know any of this stuff, but it's the same as rituximab, but it's just a souped up version. It's more potent, and you get a better cell kill with it, with perhaps slightly more side effects than with rituximab, but really not too significant. So the study that I'm just going to briefly show you here is looking at this Obinutuzumab, which is the new antibody. So chlorambucil alone, new antibody plus chlorambucil, and then chlorambucil plus the existing antibody. So these are patients who've not been treated but have a high SIR score, so generally patients who are a little bit older and a little bit more frail and have other problems, and possibly also with some kidney functions. So these patients wouldn't be fit for fludarabine-based therapy. And again, you've got your two curves here, and doctors love these kind of graphs because it's just easy to look at the pictures. And so the orange line doesn't do quite as well as the blue line. And so the blue line is the new antibody plus chlorambucil tablets. The orange line is the old antibody rituximab plus the chlorambucil tablets. And you can see there that this is progression-free survival, so the time it takes for the disease to come back after your chemotherapy. And on average, within 15 months, half of the patients will have a recurrence of disease with rituximab, whereas it takes an extra 11 months there, so almost a year longer before the disease comes back with the new antibodies. So there's a significant benefit there in the time for that disease to come back. So this is an extra year in your life when you don't need to have any treatment, so that's a big thing. New antibody versus the old antibody, an extra year of life without the disease coming back, so a big benefit. But then you've got the even newer things. So these really are just rehashing the old ideas, antibodies plus chemotherapy, but, you know, modifying them a little bit. And there's certainly some benefit there. But now we're looking at the next step, which is looking at things in a totally different way. So this is a, you know, a fairly complicated cartoon of how cells work. So you have on the outside, this is the cell in the middle of the cell, and this is the membrane of the cell, and this is outside the cell. And what generally happens is hormones, chemicals bind onto these receptors on the cell surface and stimulate chemical reactions, stimulate processes within the cell, and those processes encourage the cells to either grow or die or maybe change into other cells. So we know that we know a lot more about the chemicals involved, the enzymes involved in all of these systems, and we know that some of them, for instance, this one here, BTK, is called Bruton tyrosine kinase, and there's a very rare disorder which occurs in it's linked to the X chromosome, so it only occurs in young boys, and they're born with a deficiency of this enzyme, and that results in them having severe infections. The B lymphocytes don't work normally, and they get severe infections. So on the basis of that, people realize that BTK is an important enzyme in B cells, and so scientists have gone on to try and get drugs that will interfere with this and try and use it to stop the growth of leukemic cells. Similarly, we know some other enzymes here, and the little sun symbols are areas at the moment where we have drugs, and I'm going to talk about all of those three, that we can potentially block and try and stop the growth of leukemia. So BCR, so I'll go start with this one, is B-cell receptor signaling. So things bind onto here, stimulate all of these pathways, these arrows going down, which then ultimately result in either cell survival or cell death. So the ones that are particularly important and which I'll mention are these BTK, Bruton tyrosine kinase inhibitors, Ibrutinib, and then I'll talk a little bit about idelalisib, which is a different pathway. So Ibrutinib, and again, you don't need to know any of this stuff, but it's a very selective drug. It just inhibits this Bruton tyrosine kinase there, so which means it has little in the way of other side effects. It's given as a tablet, and it can be given once a day, and it lasts for a long time. You see, it binds onto that receptor for a whole day, so it's a very selective and easy to take treatment, and it seems to be, you know, mainly on B cells, doesn't seem to affect T cells or these natural killer cells. And it works in a slightly different way. It promotes apoptosis, which is a fancy word for cell death, and also interferes with the adhesion, the sticking of these leukemia cells in the bone marrow and in the lymph nodes, and also the migration, the movement of the leukemia cells around the body. And that's why, so it has some strange behaviors, and so what actually happens is, if you start on this Ibrutinib drug, the tablet, this is your lymphocyte count, and what happens is when you first start treatment, in fact, your white count goes up. So you can see here it can you know, increase from 50% to 450%. So in the first 3 months of therapy, often the white count will get worse, and people think, oh, the drug's not working, the leukemia is progressing, this drug's useless. But in fact, if you persist with it, and fortunately people did persist with it, you can see that in 3 months, 6 months, it actually starts to come down. So if you look at the blood, then the lymphocyte count will go up, and it looks like leukemia's got worse. Whereas if you look at the size of the lymph glands, and this is the sum of the product of the diameter, so just basically looking at the height of the gland and the width of the gland, looking at how big it is basically. So you can see if it starts off at 0, then within a month you've got a 25% reduction, 50% reduction within 2 months, and say 75 within 3 months. So the lymph glands are actually shrinking down, whereas the white count is going up. And that's what's unusual about this Ibrutinib and idelalisib as well, is that things in the blood count, it looks like things are getting worse, but in the lymph glands, things are getting better. So if you do go on one of these drugs, hopefully your doctor will warn you about this, but you may see these changes, that are occurring in you. So you have to keep on it for many months, and you can see these patients are out to a year on treatment. But the glands shrink right from the beginning, but initially the white count will go up and then come down. So that's a normal effect and nothing to be concerned about. So most of the studies look at patients who've got the blue line, which is relapsed refractory disease. So these are patients who've had lots of previous treatments, and these drugs are all new drugs essentially are tried out on patients where there's very little in the way of alternative therapies. So these patients have had lots of treatments, and there's not really too many other options for them. And these drugs still work very well, despite the fact that everything else has failed. So you can see here, you know, over half of them have still not progressed by 3 years. So you've got responses of drug which are lasting over 3 years, which, you know, is very impressive, given they've usually had things like fludarabine. I think on the study, you know, I can't remember, it was, you know, they'd had 4 or 5 previous treatments. And in fact, what's even more impressive, if this TN stands for treatment naive, which basically means if they've not been treated previously. So if you give this drug in people who've never been treated for CLL, you can see that virtually nobody relapses by, you know, 30 months there, by almost 3 years. So it looks like the earlier you treat people, the better the treatment works, and that may well make a major difference now to the way we treat people with CLL. So in fact, we may stop giving chemotherapy drugs completely and go on to something like Ibrutinib, because the responses are so good, and also dramatically better if you give them at the beginning rather than wait until people have had chemotherapy and it stopped working. So, you know, look, I'll skip that one because it probably doesn't add too much for us. I guess the other thing is that if you look at again this P53 mutation, they still don't do quite as well. Ibrutinib is better. If you remember the P53 graphs before, the curve was coming down like this, whereas now it's a little bit better, but still not quite as good as everybody else. So it's an improvement, but you know, we're still not quite there. We need to work on that a little bit more. And so I'll try and finish very quickly now. So idelalisib, I mentioned the previous one was Ibrutinib. This acts at a slightly different pathway, but again interferes with signaling within the cell. Again, it's a tablet therapy. This is just an example of a patient who had the idelalisib treatment. So beforehand, you know, this lady had had 5 previous treatments, including FCR, the standard treatment. And you can see here all of these swollen glands underneath the jaw and in the neck. And then, you know, with the treatment, you know, dramatic response there. All of those glands have disappeared. So you often see very, very dramatic responses in these patients, and often quite quickly. And in fact, this is one of the patients we have at PA who had idelalisib as well. In fact, he's on a trial where patients get bendamustine rituximab, and there's a 50-50 chance either they get a dummy drug or idelalisib. So we don't know for sure what he had. But you can see here, over time, his white count getting slowly worse, and lymphocytes going along with that. And then he had his treatment, and the white count, you know, just plummeted down there. And again, you can see here, so he didn't get that initial rise in white count, but he actually got a very rapid drop in white count. And you can see here, on the 22nd of April, it was 140. A week later, they'd gone down to 4. So very, you know, very effective treatments. Again, usually with idelalisib, you do get the same kind of thing, and this is really just showing it. So the blue line is the lymphocyte count going up, and the orange line is the lymph nodes improving. So lymph glands shrink, get better, but the white count initially goes up and then comes back down again. Okay. And then, you know, what happens, I mean, you know, is there any benefit to adding in the rituximab, which you know is chlorambucil plus rituximab is better than chlorambucil alone. So if you add rituximab to one of these new drugs, is that better as well? So if you add it to idelalisib, you know, again, it does seem to work better. And in fact, in the patients who had, and this is frontline treatment, so patients who've never been treated. So again, you know, very good. You know, 2 years, none of them have got recurrence of disease. And in fact, those are in the patients with this P53 mutation, which usually the graph would be coming down like this. And again, all of the other patients, you know, doing generally pretty well. You know, like you'd have to follow this out a little bit further to a few more years to really see, but it looks like the combination of drugs may well be better as well. And these are all things that will happen over the next few years. And again here, if you give idelalisib plus rituximab, and these are in patients who've been previously treated. This first one is treatment patients who've never been treated. This one is if they have been treated. So as you can see, they don't do as well as if the first line treatment. So if you just give rituximab alone, which is something that we do, you know, within about 6 months, half of these people will have progressed. Whereas if you give idelalisib plus your antibody, you know, you're going out to well over, you know, 14, 16 months here. before people are progressing. So again, it probably adds an extra year of disease-free and quality of life before you need additional treatment by adding in this new drug. So they look to be, be very, very good drugs and very simple to take and very effective. Then the last one I'll just very briefly mention, this is a drug that looks like it may be particularly good in this group of patients with the P53 mutations where they don't respond as well to other therapies. I won't go into any detail. It's very, very good, but sometimes it does cause problems with a very rapid cell kill, and a few patients have been made very sick by this therapy. So it's something that's on trial. So if you had a P53 mutated CLL, this is something that your doctor might be looking at trying to get you on, because this treatment does look to be particularly effective. Okay, I'll probably skip that. So I'll just go to the conclusions. We'll finish there because I've taken about 50 minutes. So things that have changed really, the newer antibodies, so rituximab has been replaced by Obinutuzumab. Well, rituximab is still available, but the newer CD20 antibodies look to be even more effective, and that will be something that will change over the next few years for patients. There's lots of new agents, the idelalisib, the Ibrutinib. They're very, very good drugs. They're much more selective than the chemotherapy is, and they don't have too much in the way of side effects. There's a few side effects, but really some diarrhea, some stomach upset, occasionally a little bit of bruising, but other than that, relatively well tolerated. Ibrutinib has been approved in the United States for CLL this year, and idelalisib looks like it probably will be by the end of the year as well. So certainly in the US, these drugs will be available. In Australia, they're not, and we're usually 2 to 3 years behind the US, but hopefully we'll get a little bit quicker. So these drugs are very effective, and then there are other generations of drugs which are really not talked about, which are going to be coming on over the next few years subsequent to that. So I guess really the final point really is that things are changing in CLL, antibody treatments are changing, and we're looking at newer therapies which are not strictly chemotherapy, much more disease specific, and with much fewer side effects. So really, very, very good time for treatment of CLL people, and I'll finish there, and hopefully you should all be able to ask me any questions you need to.
Our first question is, for someone with CLL who hasn't started any treatment, would you recommend having vaccinations for shingles, hepatitis A, and hepatitis B?
Okay. Right. So we don't routinely do that, is the answer to that. Often we do screen for hepatitis B and hepatitis C in patients who present with leukemias. So if they don't have the disease, no, we wouldn't routinely vaccinate for Hep B and Hep C. For shingles, again, look, the vaccination is probably a reasonable thing, but we have had a study looking at actually doing that in patients, but we don't have any results as to how effective that is. Several of these therapies, though, in fact, we actually do give treatment with drugs which suppress the growth of particularly shingles. So a drug called Valtrex is a common one. So really for people on things like FCR, we would probably use Valtrex. Rituximab alone, you probably don't need that. Chlorambucil, you probably don't need that either. But yeah, the more intensive therapies, we would give prophylaxis with a drug against shingles, but we don't vaccinate against it, and we don't vaccinate against Hep B and Hep C.
Okay. Second question. This comes from a patient who says they haven't started any treatment yet for their CLL, but they have an enlarged spleen. Will the spleen reduce in size after CLL treatment?
Yes. So, yes, it does. I mean, the spleen can get huge sometimes. I mean, the spleen normally just under the left side of the ribs, and it's about the size of your fist. But in CLL, sometimes it can get to be several kilograms in weight and grow right down past the belly button, even into the groin area.
Okay.
So it can get pretty big. But yes, when you treat the disease in the same way the lymph glands shrink, the spleen shrinks as well.
Okay, great. And we might just do one more question. How long does the immune system need to be supported post-chemotherapy?
Okay. Difficult question. But, people will be the leukemia is a disease of your immune system. So the chemotherapy that's given, will damage the immune system. I mean, it's inevitable, unfortunately. For most people, it's not really a major problem. With some patients with CLL will have intravenous antibodies given on a monthly basis, and that treatment, that treatment may go on for many years. Generally, your immunity will have recovered. The worst culprit's really fludarabine is something that really suppresses your immune system, and probably for 3 to 6 months after the fludarabine, maybe up to as long as a year. Whereas the other drugs like rituximab, chlorambucil, much less. And really, what they tend to make you more prone to is viral infections. They won't make you susceptible to necessarily to pneumonia or bacterial infection, but viral infections, yes. So things like shingles and your average coughs and colds. I mean, there's some rare chest infections that people can be susceptible to as well. So look, I guess the answer is that you will be, your immune system will be susceptible for 3 to 6 months, probably after most kind of chemotherapy, but generally it's relatively mild and usually not a particular problem.
Okay, we might just squeeze in one more question actually. So this comes from a patient who says they are 4 cycles into a 6-month cycle of FCR and they're still having night sweats. So is this normal?
Okay, it depends on how much disease they had to start with. So, the sweats can be often related to the metabolic effects of the leukemia. So if you had very large nodes or a very big spleen to start with, then even after 4 cycles there may be still some residual lymph glands or spleen that are present. So yes, you may still have some sweats and things. I mean, I don't know that I wouldn't be particularly alarmed about that. If the white cell count is dropping, if the lymph nodes are shrinking, and the doctor will be able to give them an idea of how they're responding to therapy and whether it's working or not. So if the doctor's happy that the white count's dropping, the lymph nodes are shrinking, then that's probably more important than the persistence of the night sweats. And yeah, look, sometimes you do see that even though things seem to be going very well, patients often do still complain a little bit of the sweats and loss of appetite and things like that. So I guess I'd say I wouldn't be particularly concerned about that. If as long as everything else is going well, don't get too concerned about that.
Okay, all right, then we'll wrap that up now. And I just wanted to say a very big thank you to Dr. Wood.
So thank you.